we'll be discussing OSCEs today. Most of these will be, spotters, useful to everyone. Even if you're not appearing for DNB or MD, I mean, this would be a good learning lesson for all of us. Okay, so that's what the plan is. Keep answering because how I have planned these is you'll have to write in the actual exam. Those of you are actually exam going, how you can approach all of these OSCEs is just keep a piece of paper, watch it when it's not live and just try and write it on your own and then just see the discussion on 1.5 or 2x, and that should help. 20 spotters we have. I'll try and answer in the chat. 11-year-old with joint swelling and multiple soft tissue painful lumps. I'm showing you the X-ray of the elbow AP and lateral view. What do you think? So these are the 3 questions. Describe the findings. What is the diagnosis? And list DD of epiphyseal enlargement. So sometimes when you're not sure, read all of the questions and that'll also give you a hint of what could be the possible diagnosis, which it does in this case. So what are the findings? Let's describe the findings first. So what we are seeing here on the AP view of the elbow is that there is indeed epiphyseal enlargement of the radius. You can see joint space narrowing. You can see this irregularity and sclerosis of the joint, right? So we are seeing that there is epiphyseal enlargement, joint space thinning, as well as sclerosis. On the lateral view also, we can see some irregularity as well as sclerosis of the bones here. What do you think is the likely diagnosis? So I forgot to tell you this is a boy. So 11-year-old boy who has joint swelling, lot of painful lumps. What does this all add up to be the most likely diagnosis? Or anytime we see this sort of an epiphyseal enlargement, what are the things that are more likely? Nobody's answering. Tell me at least what would be the diagnosis. Perthes. Perthes can show epiphyseal enlargement, but in final end stages, it may show. Extramedullary hematopoiesis. The very word, what does extramedullary hematopoiesis mean? It means that it's happening outside the bone marrow, right? So it's going to happen in soft tissues. It's going to happen in the paravertebral region. Joint is not the place for extramedullary hematopoiesis. Tremors is one differential, but tremors will not have rest of the joint getting involved. It'll have one epiphyseal enlargement. So I can definitely include that. Finally, so this indeed is hemophilia, one of the most important associations of epiphyseal enlargement and, young boy, joint swelling, multiple soft tissue painful lumps or multiple soft tissue painful lumps. What you want to remember here is this is all linked with hemophilia, right? So there can be multiple such ecchymotic swellings which are there, okay? Medullary calcinosis associated with rickets? No, it's associated with hypercalcemia more commonly, not with rickets. So it could be 2 independent findings. Maybe there can be medullary sponge kidney, which is leading to calcinosis, and then rickets is just add-on, which is a very common nutritional deficiency in our country. So, yeah. So basically the findings here we have to describe as epiphyseal enlargement of the radial head. What else do we see? We see sclerosis and irregularity of the joint space. So sclerosis as well as irregularity of the joint space indicating arthritis. Okay, so we'll soon be having an approach to arthritis class as well. So this is that. So the likely diagnosis here is hemophilia, right? So this is hemophilic arthritis. DD of epiphyseal enlargement, very, very important. Apart from hemophilia, JIA is the first thing you want to say. Whenever you are talking about epiphyseal enlargement, 2 things are the top of the list. One is hemophilia and one is JIA, juvenile idiopathic arthritis. Then you may also have Trevor's disease, like one of you said. So Trevor's disease, you remember I taught it to you. So Trevor's disease is a dysplasia where you have epiphyseal enlargement, which is a sessile osteochondroma arising from the epiphysis. And one of you said Perthes. So Perthes ke end stage, healed stage mein you may have epiphyseal enlargement sometimes, okay? So this is what you need to remember. Just one more thing, it's not very, very well seen, but if you pay attention, can you see a posterior fat pad? it is clear. I mean, can you see a differential fat density? Now that I pointed out, probably you can make it out. So we can also see the posterior fat pad. What does this indicate? What is posterior fat pad sign? So normally what you will see on a lateral view of the elbow is the anterior fat pad. Posterior is not seen. When you start to see posterior, very good. This indicates effusion, not fracture. It may have underlying fracture in most cases because effusion is an indirect sign of fracture. But in this case, it's effusion, right? Because of hemophilia. So this is what is the posterior fat pad sign. So this is important. So normal cases may we see this. Sorry. Normal cases may we see this. This is how it normally appears where the anterior fat pad is visualized, posterior is not seen. But in effusion cases, we start to see posterior as well. So when you start to see this rim of fat at the posterior fat pad, this is what is indicative of effusion, right? So this anterior is normal and it should be parallel to the distal humerus. But when anterior is also bulging, like in this case, can you see it's bulging out like a sail? So that's one, and posterior becomes visible. That is because the effusion is what is pushing it. And this is usually a subtle sign because in a lot of cases, these supracondylar fractures, we may miss them. So this is the indirect sign that there may be underlying fracture. If you don't see it on X-ray, get a CT done. So this is very useful. Okay, so that's the learning point here. So now we know learning lesson. We know features of hemophilia. More commonly, you'll be shown knee X-ray. Knee X-ray, I think you guys know. In knee X-ray, it looks something like this where the epiphysis is enlarged. And what you will see is that the intercondylar notch becomes very prominent. So on knee, remember the findings, same findings, epiphyseal enlargement with intercondylar notch becoming very prominent and the patella becomes squared. So these are the signs of hemophilia. Occurs in boys. Hemophilia A and B are factor 8-9 deficiencies, which are X-linked recessive, whereas hemophilia C is factor 11 deficiency seen in any gender because it's autosomal recessive. So these are the points here, and this is very important takeaway. Okay, next is this. First, learn what I'm teaching. Yeah, what is this? First, you need to remember A, B, C, D, E. What are these points here? So, identify A to E. What is point A? Tell me answer to this, then I'll take up any request of yours. Is it pituitary? So, we focus on what is being taught. Cell class already done. So this is pituitary, right? So this is what is pituitary. So this is anterior pituitary, this is posterior pituitary. And we can see that this is posterior pituitary hotspot, right? So can't go wrong. Yes, a basic mistake nahi karni. First year mein we have to learn all of this very quickly, right? So this is what is mammillary body, correct? So A is mammillary body. What is B? What is B pointing to? So B is the diamond-shaped ventricle here. You know this. This is the fourth ventricle, right? So B here is the fourth ventricle. What is C? What is C? We have seen a case of glioma here. This is tectal glioma, right? So this is basically tectum. If you have obstructive hydrocephalus with glioma, this will be tectal glioma. So this is the corpora quadrigemina or the tectal plate. So this is tectum. What is D? You do get one radonat in every OSCE, so becomes very important, and also for FRCR. What is D? Yes, D is the tentorium, right? So D is tentorium cerebelli. Whenever you have tentorium being raised or this confluence, which is the torcula being raised, you have to suspect a posterior fossa enlargement, right? So this is what is the hallmark here, that this becomes raised. So what is D? D is tentorium cerebelli. And what is E? E is tonsils, right? So E is the tonsil of cerebellum. Complete answers will be better, right? So that's what you do in the exam. What is the criteria for cerebellar tonsil herniation? So there are many criteria. The one which is most commonly followed, we draw a line. Do you know what is the McRae's line? So McRae's line is the point connecting the basion to the opistheon. So this is basion and this is opistheon. So the line connecting basion opistheon, if the tonsil is 5 millimeters below the McRae's line, that is what is called as cerebellar tonsillar herniation. And it's a finding of So what you have to write is, draw a line which is the Macrae's line, which is connecting the basion to the opistheon. And if the cerebellar tonsil is more than 5 mm below this line, this is what is tonsillar herniation. And yes, this is indicated with Arnold-Chiari type 1. So this is a sign of Arnold-Chiari type 1 malformation. Okay, so that is what we are seeing. In this case, it's a normal cerebellum, not below the Macrae's line. Right, so this is anatomy based question. This is what we see. The CVJ anatomy is pretty complex. I'll take this up as a class in June or July to understand the anatomy here. Okay. Third, again, something which is a